Hello, everyone, and welcome. I am Christina Hawes, the Community Engagement Coordinator for Community Outreach and Engagement Office of Wilmot Cancer Institute. And I'd like to welcome you to today's webinar, Human Papillomavirus, or HPV, the who, what, where, why, how of prevention and disease. This webinar is part of our Community Conversations on Cancer series, an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. It is sponsored by the Office of Community Outreach and Engagement, CERTEC, and the Community Cancer Action Council, or CCAC. This live event has been approved for 1 AMA PRA Category 1 credit, 1 CNE credit for nurses, and 1 contact hour for social workers. If you would like to receive credit for attending, make sure to fill out the post survey. The link will be provided when this webinar closes, as well as in a follow-up email. Our presentation today will be followed by a facilitated Q&A session. Throughout the presentation, please feel free to enter any questions in the Q&A box located at the bottom of your screen. Now, let me introduce our amazing panel of experts. Erica A. Bostic, MD, is board certified in internal medicine and adolescent medicine. Clinically, she specializes in caring for adolescents and young adults in the fields of gender health, eating disorders, and sexual reproductive health. She currently is a faculty member on the Clinical Education Initiative, which provides sexual health-focused education to clinicians, as well as the site principal investigator for the HPV Impact Project, a CDC-funded grant. Marielle Stevens, MD, is board certified in obstetrics and gynecology, as well as clinical informatics. She has a clinical passion for cervical cancer screening and precancer treatment. This fits nicely with a large interest in systems-based care and quality improvement, leading to a focus on how to best screen and treat a whole population of patients. Next, we have Rayanne Kurtz, who holds a bachelor's degree in public health and is currently pursuing a Master of Public Health from the University at Albany's School of Public Health. She also holds an advanced certificate in public health fundamentals and principles. With 8 years of experience at the Emerging Infections Program, she has been the lead epidemiologist for the HPV Impact Surveillance Project since 2021. Her expertise lies in epidemiology and public health surveillance, contributing significantly to the understanding and control of infectious diseases. She is passionate about advancing public health initiatives and improving community health outcomes. We then have Dana Van Valkenburg, who graduated with her MPH degree in infectious disease epidemiology from Cornell University in May 2024. She joined URMC as an epidemiologist for the Emerging Infections Program in June 2024. Her interests include HPV-associated cancer prevention and using clinical and translational research to improve the public's health. And finally, we are very excited to welcome Wendy Bruner, PhD. Wendy is an epidemiologist and the director of the Center for Rural Community Health in Bassett Research Institute at Bassett Medical Center in Cooperstown, New York. So welcome to all of our amazing speakers. I will now hand this over to Dr. Bostic and the UR team.
Thanks so much, Christina, and thank you for having us, and welcome to all the community members who are joining us today. We'll go ahead and get right started. Okay. So by the end of this talk, we hope you'll be better able to describe what HPV is and how infection develops, to identify different HPV prevention strategies, specifically knowing more about the HPV vaccine and pap testing, and lastly, understand national and local epidemiological trends of HPV-associated cervical precancers and cancer. And so we'll jump right in. So big picture, HPV is one type of virus in a family of viruses, but includes over 200 different subtypes. Those viral types are often stratified into high and low risk, the lower risk types usually causing warts, while the higher risk types can lead to cervical and other types of cancer, where we will focus today. When we look a bit further into the associated cancers, you can see cervical cancer is the predominant HPV-associated cancer for those assigned female at birth. And for those assigned male at birth, oropharyngeal cancer, particularly those at the back of the throat, are most common. So while we're focusing today on cervical cancer, please know that there are many cancers associated with HPV that affect both males and females. So how does one become infected with HPV in the first place? And the answer is sexual contact. HPV is the most common sexually transmitted infection, or STI. About 80% of sexually active people may have or have been exposed to HPV. Many people are able to clear the infection, and we'll talk more about how that has gone into the recommendations of when to start screening. But we need to keep in mind that this can linger and lead to cancer, which is why cervical cancer screening via pap smear and receiving the HPV vaccine ideally before sexual activity begins are such powerful prevention tools. But let's talk a little bit more about what increases a person's risk for both primary HPV infection and risk associated with progression to cervical cancer. So risk factors associated with infection include number of sex partners, simply because there's more opportunities for exposure, and younger age at first sexual encounter, and that's because there's just a longer total time frame to potentially be exposed. Risk factors for cervical cancer specifically include infection with a high-risk strain, and we talked about those. Over 9 out of 10 samples of cervical cancer cells, when looked under the microscope, are seen to have one of these high-risk HPV types. Smoking tobacco is another risk for many types of cancer, including cervical cancer, and we don't really know too much about the risk associated with vapes and other sort of newer products, and that doesn't mean they don't come with risk, but we just haven't studied it yet. A weakened immune system. So we talked a bit about how many people can clear this infection by themselves, but we don't know who that group will be. And if your immune system's already on the lower side, you may have less likely of a chance to clear the infection and therefore more likely a chance of it progressing to cancer. And like other cancers, there may be a genetic component related to it, so a family history of cervical cancer could put you more at risk. And one of the most powerful risk reduction strategies for both infection to begin with and progression to cancer is, of course, the HPV vaccine. So now that we know a bit more about the virus, what it can cause, what increases the risk of infection and potentially cancer, and how one gets infected, let's talk a bit more about general trends. So when we look at specifically cervical cancer, this graphic shows the burden of cervical disease annually in the US. So nearly 200,000 women are diagnosed with cervical precancer. A little over 11,000 women are diagnosed with cervical cancer caused by HPV, and about 4,000 women die from cervical cancer. And so these numbers may be smaller than other types of cancer, but I think this audience knows better than most that each one of these, cases is a person's life at stake. And so really any number is too big of a number. The other thing that I wanted to add is about 4 out of every 10 cases of cancer caused by HPV occur in men. So every year in the US, not shown on this graphic, over 15,000 men get cancer caused by HPV. In too many spaces, both in and outside of healthcare, there continue to be disparities. So in terms of race and ethnicity, we've seen that non-Hispanic white and Black males are disproportionately impacted by high-risk oral HPV, and those can lead to oropharyngeal cancers like we talked about. Non-Hispanic Black males and females are disproportionately impacted by high-risk genital HPV, so that could be cervical cancer, but also penile, anal, rectal cancers. And more so, we also have disparities outside of race and ethnicity, and so we know that many disparities exist in the LGBTQIA+ population, and we know that HPV infection is 2 to 5 times higher in men who have sex with men compared to men who have sex with women. And so we'll shift gears a little bit and go more into detail about HPV prevention. At the risk of sounding like a broken record, the best way to prevent HPV infection in the first place is the vaccine. And so we're lucky to have one of the only cancer-preventing vaccines readily available. Here you can see a timeline of the evolution of the HPV vaccine. So starting in 2006, when the vaccine was approved for assigned females at birth, it was for ages 12 to 26. About a year later, stronger language in the recommendation was put out, emphasizing starting the series earlier, so closer to the 11, 12, but as early as 9 actually would be ideal because at that age, usually it is prior to the onset of sexual activity. Let's see. And in 2011, the vaccine was approved for males. And as time went on, more HPV subtypes were added to the vaccine. And currently we have a 9-valent, so 9 different strains are within the one vaccine. In 2019, clear catch-up recommendations were made for those who missed vaccine opportunities in childhood, as well as guidance for shared decision-making for those up to the age 45, so well beyond childhood. And the bottom line is, and sort of big takeaway here, is the HPV vaccine is a cancer-preventing vaccine that is over 90% effective in preventing persistent HPV infection that can lead to cancer, but also cancers, and so including cervical precancers. This is a visual schematic of the dosing schedule for the HPV vaccine series. So kind of key features here. The earlier you start the series, so for example, between ages 9 and 14, the fewer shots you're likely needed to have. So if your first shot is at 15 years of age or older, you're likely going to need 3 shots. But if you receive your first dose between the ages of 9 and 14, you likely will only need 2 shots. If you get the next dose too soon after the first dose, you will have to restart the series. But the good news is if you have a longer period of time than designated between doses, you likely don't have to repeat the series. And if you received an older version, so we talked about how later on the 9-valent one came around, there were earlier versions that were less than 9, you don't necessarily need to repeat the series. If you had an older version of the vaccine, you can just complete the series and then you're protected. If you're 18 to 26 years old, you're still eligible for the HPV vaccine series. It'll likely be 3 doses, again, unless that first dose was at less than 15 years of age. And if you're between 27 to 45, talk to your medical provider about getting the vaccine. You're still eligible, and providers use a shared decision-making model that's described here. There are a few special considerations that you can see for those in an immunocompromised state, for those who are victims or survivors of sexual assault, and the HPV vaccine should not be given in pregnancy. There are many ways to access the HPV vaccine. Many are listed here. In terms of out-of-pocket costs, for those less than 18, rarely there is any. For those who are a bit older, there's various ways to mitigate that cost to be either little or none. And so talk to your medical provider if you have concerns about it, and they can give you more information. And there's really no reason to reinvent the wheel. Australia is a great user case if you want to see how a successful vaccination program can happen. Of course, there are multiple variables, some that are similar in the US, some that are different. But I think the big picture here is that we could all learn something. Many countries, including our own, can learn something from the success of Australia. And now I'll hand it to my colleague, Dr. Stevens.
Hello. So after we think about the HPV vaccine, which is really sort of primary prevention for cervical cancer, we then move on to our next prevention strategy or secondary prevention, which is really screening for cancer. And luckily, we developed a test for that is quite good as compared to a lot of other cancers that are out there. So the Pap smear or Pap test actually is named from Dr. Papanicolaou, who created this test. And because that is a lot to say, that is why it got shortened to Pap smear. It is basically just taking some cells from the cervix and looking at them under the microscope. And so that's what the picture here is about, is they put special stains on and try to determine if the cells look normal or abnormal. We also understood, as the beginning of this talk certainly highlights, that HPV is the main causative factor for cervical cancer. So in the last several years, we've started also testing for HPV. Usually this isn't done until the age of 30 or older because HPV is incredibly prevalent, and we would probably cause a lot of undue concern if we started testing a lot earlier. So we can use both of these tests together in different combinations as our screening strategy. And I found this a really nice visualization of what it is to have a pap smear done. It turns out this is really hard to explain. It's hard to explain one's anatomy. So the metal speculum is placed in the vagina to visualize the cervix. The cervix is really nothing more than the opening to the uterus. We look at the cervix and then use a tool like this broom here to get some cells off the cervix. That specimen can also be used to test for HPV or just to test for HPV primarily. But that is what's happening when someone does a pap smear. So then the question is, how do we screen people and how often do we screen people? We have, as compared to a lot of things in gynecology, a lot of evidence around HPV and cancer and precancer and how it behaves. And so over the last several years and continuing, we've been updating our screening recommendations to try to find a nice balance of not testing people too frequently, because the harm of testing people too frequently is we find abnormalities that don't end up being a problem, and making sure that we still keep people safe and prevent cervical cancer, which is the whole point of this. So most commonly right now, locally, and I would say probably nationally, most people start screening it at the age of 21 with the pap test only. And like I mentioned, we try not to test for HPV in young patients because it is very prevalent. It often goes away on its own. So we start with the pap test just to see if there's been changes to the cells every 3 years, if it's normal. And then starting at age 30, add the HPV test. There's a lower rate of HPV infection in women as they get older. And so now if we look to see if they have HPV or not, when they have a normal pap test and a negative HPV test starting at the age of 30, we say they can be screened every 5 years because the chance of developing cervical cancer in the next 10 years with that result is very, very low. This table here goes through some of the alternative screening regimens. And as I mentioned, this is something that is constantly evolving. So probably the next step, which is about to come out, is actually that we just start with the HPV test and only test for HPV. And if it's positive, then follow up with a pap smear to then determine what to do. So that is probably coming soon, is a little bit simpler. So then what happens if you do have a pap smear that is abnormal? Because we have so much data now on how HPV behaves and pap smear testing abnormalities and what happens to most patients with those abnormalities, we're able to take an individual patient, their age, their last pap smear, and put it all together to decide what to do next. So some people with the same result just need a repeat pap smear at some shorter interval than 5 years. And some people, we feel like the risk that there is a precancer that we need to treat is high enough that we have to go to the next step, which is a colposcopy. And during a colposcopy, we do the same exam as before, where you put the speculum in the vagina to look at the cervix. And this time we look with a microscope to try to identify the areas that made the pap smear abnormal and to take a biopsy. And that is how we determine whether or not there's a precancer that we need to treat. So as it happens, if there is a very mild precancer, not listed here, CIN1 or nothing on these biopsies, then we will plan to follow along. But if it is worse than that, if it is CIN2 or worse, then we treat by trying to remove a portion of the cervix to prevent progression to cancer, which is shown here on this slide. And as Dr. Bostic mentioned earlier, the rates of actual development of cancer are really quite small, and it's all because the pap test, which was our first original test, plus the other testing we've done, can be very effective to prevent getting actually all the way to cancer. So signs or symptoms of cervical cancer. And I will also be honest, I've been in practice for 16 years as a general OBGYN, and I have seen very little cervical cancer. But abnormal bleeding is one of the main signs. Very typically, bleeding with sex is a feature that most people can associate with cervical cancer. However, most bleeding with sex is not, in fact, cervical cancer. Pain, yes, there would certainly be pain. It can be pain if there is a lesion on your cervix that is cancer. Unfortunately, when cervical cancer progresses, it can be quite aggressive. And so if we get past the point where we're treating early with procedures that I do, it does progress and can get throughout the body. So you can have nausea, vomiting, and urinary symptoms, weight loss, loss of appetite, etc. So we wanted to go over some common myths after this section. One is that if you get the HPV vaccine, it will allow kids to start sexual activity or make them have sex sooner. False. So the vaccine not only decreases infection of this most common STI, but prevents cancer. It's a routine part of childhood vaccinations, and there's no evidence to suggest that speaking about the vaccine or getting it changes sexual intent or behavior. Another one is HPV vaccine or other vaccines cause autism. That is also false. Arguably, one of the most detrimental failures of peer-reviewed academic journalism is this now famous paper published by Dr. Andrew Wakefield in The Lancet that implied that the MMR, right, that's measles, mumps, and rubella vaccine caused autism. It has since been retracted, but has unfortunately led to that concern with many different vaccines. And last but not least, one that I brought to the table is that every time you have a speculum exam, you have a pap smear done. So that's not true. The speculum exam is merely putting a speculum in the vagina. We do that for a lot of other reasons, sometimes to test for sexually transmitted infections, to assess for bleeding, etc. The pap test is done during a speculum exam, but certainly not all speculum exams include pap smears.
Thank you, Dr. Stevens. Next, I will be giving an overview of the HPV Impact Project and taking a closer look at cervical precancers in Monroe County, New York, and what we are currently doing to better understand how HPV affects our community. The New York Emerging Infections Program, which is funded by the CDC and part of the UR Medical Center, housed within the Center for Community Health and Prevention. We are a part of the Communicable Disease Surveillance and Prevention Program, and our team of epidemiologists and physicians study infectious diseases that are impacting the public's health. There are 12 EIP sites across the country, with only 5 EIP sites that collect HPV-related data. The sites collecting HPV-related data across the country are designed in a way in which it is representative of the U.S. population. Our role within EIP is to identify disease trends, establish and strengthen health programs, and disseminate findings which inform state and national policy, as well as healthcare practices and public health practice. Now that you know about what we do at EIP, I will briefly go over the EIP projects at URMC. They are categorized into 4 groups: healthcare-associated infections, community interface, viral respiratory infections, HPV impact, which we will be discussing today, Thank you. And special projects. I wanted to point out that New York HPV impacts catchment area is only one county, which is Monroe County, and some of the other projects have an expanded catchment area that is indicated with an asterisk. If you or anyone would like to learn more about EIP and our team's other projects, please be sure to scan the barcode in the upper right-hand corner of this slide. Next, we will be taking a closer look at what we do for the HPV Vaccine Impact Monitoring Project, or HPV Impact. HPV Impact is an active laboratory and population-based surveillance as part of the CDC Emerging Infections Program. The main purpose of our surveillance is to monitor the impact of the HPV vaccine on HPV types associated with cervical cancer and cervical precancers. Some of our goals and objectives for HPV impact is to determine rates of HPV-associated high-grade cervical lesions and cervical cancer in women over time, and to obtain SIN2 plus cervical specimens on all reported cases of high-grade cervical lesions and those assigned female at birth who are 18 to 39 years of age in Monroe County. I know we briefly discussed the HPV vaccine timeline earlier in the presentation, so I won't go over the evolution of the HPV vaccine again, but I did want to point out a few important dates within our HPV impact timeline. Starting in 1943, the Pap test was introduced, which was a significant milestone in healthcare, and we now know the Pap test is very important because it allows for early detection of abnormal cells, or SIN2 plus, in the cervix before they become cancerous. Over 6 years later, in 2006, the quadrivalent HPV vaccine was approved for those assigned female at birth. 2 years later, in 2008, our HPV impact surveillance started. I think it's important to point out that in 2011, the quadrivalent vaccine was approved for those assigned male at birth as well. In 2018, our surveillance expanded to include invasive cervical cancer, and in 2019, that HPV vaccination was approved for everyone through age 45. Next, I will discuss our HPV surveillance processes in Monroe County. On a monthly basis, we receive queries from 4 local pathology labs for SIN2 plus diagnoses. We are then able to confirm all cases, and this has led to over 7,300 cases in Monroe County. Through our data collection process, we review HPV vaccine history and collect this data from NICIS, which is our state immunization registry, and from providers documenting vaccine history and patients' EMRs. We then review EMRs to complete case report forms and collect specific data, which will be discussed on the next slide. And finally, cervical specimens are selected by local pathologists and sent to CDC for HPV typing. And now I will hand it over to Dana, who will discuss our current data and how we are currently using it.
All right, so we collect a variety of data points and variables for the surveillance. For all cases, we collect demographic information, insurance status, specimen information, and overall diagnosis. For our enhanced cases, who are patients with a precancer diagnosis between ages 18 to 49, as well as our cancer cases, we collect HPV vaccine status, most recent Pap test, and HPV test. And then for our cancer cases only, we collect any barriers to screening or treatment, if the patient was ever immunocompromised, their diagnosed cancer stage, and symptoms that they presented to a provider with. And this information is collected primarily from OBGYN provider notes, emergency department notes, history and physical notes, face sheet, and the New York State Vaccine Registry. This is our workflow and cycle of collaboration with CDC about how the local data is used to inform decision-making that aims to improve the public's health. First, the data is collected, then de-identified, and then reported to CDC. And CDC helps us run data checks to identify and fix any mistakes within the data. And then we both analyze the data to identify any disease trends that we see. The specimens are prepared by our local pathologists and sent to CDC, where they identify if and which HPV strains are present within the sample. And then using this, we are able to determine which HPV strain types are circulating in our population. And then we all use that data to inform the public, healthcare providers, as well as the ACIP, which is the Advisory Committee on Immunization Practices. And they are a panel of experts that evaluates and decides to recommend a vaccine for the population or not. And data from HPV impact is used by ACIP to make decisions about the Gardasil vaccine. Earlier, we showed some national data, so now we're going to take a look at what the cervical precancer and cancer landscape looks like within Monroe County specifically. This graph is showing cervical precancer, which we're calling SIN2+, by year and by age group. So in general, across each year and age group, incidence of cervical precancer is decreasing, which suggests a positive impact from the HPV vaccine. And then here's a similar graph, except it's showing cervical cancer trends by age and by year again. And in this graph, it appears that across most age groups, cervical cancer has decreased over time, maybe except for the 65 to 74-year-old age group. But this is hard to interpret because there are so few cases, which is a really good thing. And that means that this trend that we're seeing may not be meaningful or statistically significant.
Okay, thanks Rayanne and Dana and Dr. Stevens. So we looked at the local data, and now actually I wanted to build upon that to help convey how we use this data to understand our local community, to help inform how we can keep Monroe County and the rest of the country protected against HPV and associated diseases in an evidence-based way. We wanted to share a concrete example of how we are learning from our local community and generating ideas for improvement. And so we saw gaps in screening and follow-up listed here, briefly read them. So we noticed in our own sub-study that 1 in 2 patients with cervical cancer were not up to date on screening at the time of diagnosis. So potential intervention there is more patient education and targeted health maintenance and screening, making sure those who are performing these tests or recommending that this test should be done are informed about the guidance. We also saw that 14% of patients had untimely follow-up, meaning longer than a year after their abnormal pap smear did they re-present to care. And so more ideas related to informing the public, such as yourself, and helping clinicians know more about this as well. And just briefly wrapping up, we wanted to kind of in a nice slide form have some key takeaways that you can review later, both for healthcare providers of all specialties and our community members. So please walk away from today knowing that the HPV vaccine prevents cancer. Consider talking about the HPV vaccine for people of all genders up to the age of 45. Clinicians need to check the chart and ask patients if they're up to date on vaccination, and use shared decision making if someone's over 27. The HPV is a normal childhood vaccination and should be bundled with the rest of them. There are many myths related to the HPV vaccine, some of which I hope we debunked today. And similar to checking vaccination status, also clinicians need to check if a person is up to date on their cervical cancer screening tests. For community members, again, the HPV vaccine is safe, effective, and prevents cancer. It's recommended for people of all genders up to the age of 45. Routine pap testing plus or minus HPV testing is one of the most powerful ways to detect cervical precancer and prevent it from progressing to full-on cancer. Please talk to your medical provider about these things. And though many people can clear the vaccine, and as Dr. Stevens, or excuse me, the virus, as Dr. Stevens mentioned, we don't know who those people will be. And so let's be sure that everyone is aware. And I will hand it over to Wendy.
Oh, Wendy, you're muted.
All right. Now, can you hear me and can you see my slides?
Yes, it's good to go.
All right. Thank you. What a great introduction to the part that I wanted to talk about. Just really terrific hearing the information and data. And what I wanted to talk about today was about the research that we've been doing to develop videos for parents in our region. So I'm in Cooperstown, New York, with the Bassett Research Institute, that's part of Bassett Medical Center, which is part of the broader Bassett Healthcare Network. We represent about an 8-county region in central upstate New York. And we wanted to develop videos for parents about the HPV vaccine. And so we've been doing this as part of a research project. And I'm going to tell you a little bit about the development process and then demo one of the videos for you. So to get started, you can see the data, some of the data that was driving our work. You can see that most of the counties in our region actually fall below the New York State Prevention Agenda goals for HPV vaccination, which is approximately 38%. So 38% of 13-year-old adolescents having a complete HPV vaccine series. And you can see the real variation by county in our region. This is from 2022. And so we know that one of the factors that contributes to lower rates of vaccination is vaccine hesitancy. And I have a definition in this slide here as delay in acceptance or the refusal of vaccination despite the availability of vaccination services. And the slide shows results from a national survey of parents of adolescents between the ages of 13 and 17 from the years 2018 and 2019, so prior to the COVID pandemic. And in this survey, they found that vaccine hesitancy was higher among mothers as opposed to fathers or other guardians, was higher among those mothers with lower educational levels, households with lower income households, and those not having received an HPV vaccination recommendation from their provider. And that's a key point we're going to be hearing more about in just a little bit. And parent hesitancy was associated specifically with lower HPV vaccine uptake in this survey. And so the goal of our project was to develop a set of short videos. They're all less than 60 seconds each to help parents in our region specifically in our rural region, make decisions about the HPV vaccine. And our hypothesis going into the project was that locally developed videos created with the input of local parents could be used to help parents make decisions about the vaccine. And so we convened a parent advisory board and made up of parents from our region, ended up being 6 mothers of children under the age of 15. And we met with them for 1 hour a month, over 5 months, to get their input on the videos to be developed. And we also enlisted the help of health communication experts from the University of Albany and UCLA. And they were the ones who guided the video development process and developed the video scripts based on the feedback from the parents on our advisory board. And we also benefited from having a local videographer, and you'll see how you'll see her work in just a second. We learned several key things from our parent advisory board as part of this process. And one, as we'd hypothesized, that the local context was important, including a local healthcare provider who happened to be an actor, which was really terrific, or had experience in acting, and similarly, a local parent who had experience in acting. You'll see that local scenery was key in the videos as well. We also learned from the parents that including data in the videos was important. And it was really neat for me to see the data that was presented earlier in this webinar. They thought that was really important to include as well. And then finally, it was, so going into this project, we had assumed that the videos, these short videos, would be best used in social media. And when we talked with the parents, they said, no, actually, we think these should be used in a clinical setting. And so part of our ongoing research is to figure out how that actually will take place, whether it would be through posters with a QR code in the waiting room or in an exam room, or getting the videos in front of parents through, say, the Healthcare Network's patient portal, and communications through that method. That's part of research that we're working on right now. But that was really important input to get from the parents in terms of who the trusted messenger was for this information. So I will show you on the next slide the topics that the videos cover. And if technology is my friend, I will show you one of the videos. That's all I had. Thank you.
Well, thank you so much to all of our presenters. I'm very excited. We are actually going to be getting to the portion of today's event where everyone can have your questions answered. So if you have any additional questions that you were not able to put in during the actual presentation itself, please feel free to go in and put them in at any time down at the Q&A box. We will get to as many as we can. We have about 15 minutes or so. If we have more questions and we have time, we will make sure that we answer those and send them out to you in the post-event email. So let's jump in and get started. So this is open for anyone. Would getting the vaccine as an adult help to prevent further outbreak if already infected with HPV?
Yes. So it turns out that, yeah, so the general idea is that it would protect you from HPV strains that are covered in the vaccine that you haven't been exposed to already. But there's also even some data to suggest that patients who've been treated for precancers may have a lower recurrence if they get the vaccine where they had not previously.
Okay, and this one, so with the vaccine now, let me just clarify based on what I heard stated earlier, is it prevents against 9 different strains, but how many strains of HPV are there? Do we know?
Over 200.
Okay, but the 19 or the 9 that it prevents are the ones that are most associated with risk for these types of cancers. Correct.
Exactly.
Yeah, so we have like a bucket of HPV strains that we know are most likely to cause cervical cancer, and usually maybe 13, 20 or so kind of fall in that high risk HPV category. And then we've taken 2 that we know are the most virulent, that are responsible for most of the cancers, and that's HPV 16 and 18. And so those were in the original vaccine and remain in the current vaccine. And those are the ones that we also sometimes will test for separately because they are more likely to be aggressive.
Thank you. Okay, so this one, I think, Wendy, might be directed more towards you. We have someone in our audience who's looking to conduct an HPV-related roundtable discussion in rural upstate New York. So they're looking for an interview guide or help with the right asking the right questions in the right way. So is this something that you actually have some information or some tips and tricks, I guess, based on what you were doing for your videos in your advisory board?
Certainly, we could, I could put my email address in the chat, and this person can feel free to contact me. We, as part of our research, when we produced the videos, we did conduct a survey of a random sample of parents in the region. And so there's a lot, depending on exactly what the person's looking for, we can certainly provide them with information. Yep.
Okay, perfect. I will send out your email privately to this individual
All right.
through
Thank you.
this. So if you hold on a few minutes, Kat, I'll make sure that I get that in there. Um, Next, why aren't this is a very interesting question. I actually had this one myself as we were going through, so I'm glad someone put it in. Why aren't all HPV positive samples tested for strain of HPV? It sounds like with your study right now, at least, that you're selecting specific ones that are being sent to the CDC. Is that correct?
Yes, so anyone that has a confirmed SIM2 plus diagnosis that is 18 to 39 years of age, they are sent to a local pathologist who then selects the best block and then is sent to CDC for HPV typing.
So not all samples are tested for strain. Is that
No,
correct?
not all samples. It's set by the CDC for that specific age group. And then we also have invasive cervical cancer cases where we send all of those regardless of age as well.
So, Dr. Stevens, for you as an OBGYN, is this something, I mean, for your office, if you do get a positive HPV, is this something that then gets tested for strain, or is it
Yeah,
questionable?
so that does happen a little bit differently in different places. At URMC and anybody that's serviced by our lab, which is most of the city, as I understand it, or a majority, we usually actually will test all positive HPVs specifically to see if there's HPV 16 or 18, like I mentioned, and then other. And so all of our positive HPVs get that information, and we use that to decide what to do and how quickly to see somebody back or do a colposcopy. So that's becoming more common. That it used to be that we would only look for the strains in certain circumstances because only then did it help us decide what to do. But now we're basically doing it on everyone. But just
Um,
those, not more detail.
well, with over 200, I think that yes, finding the big ones is more important than the rest. So, okay, well, I'm glad to hear that the 18 and 16 are the ones that are really being looked into. So, this is an interesting follow-up. Are the anal pap tests as effective at screening for HPV and cancer? We did have a discussion on this, a community conversation um, about a year ago that talked about anal pap tests. So that's a very good question.
I don't know too much about anal PAPs. I don't perform them, but I know that similar to other questions that are coming up, there is a desire and need to better understand other sites of the body that are impacted by HPV that can progress to cancer. So anal cancer, oral pharyngeal cancers, the head and neck cancers, we have this really data supported, well-defined guidance for cervical cancer. And the hope is that the other cancers will follow suit. We're just not quite there yet.
Okay.
But I would defer to to the talk a year ago for more details.
Okay. Um, okay, so this is a great question. If a patient has received a full HPV vaccine series, one of the earlier options, not the nonavalent one that's out now, would you recommend getting a booster of the HPV Gardasil nonavalent option?
So the CDC explicitly does not recommend that. I don't know all of the details behind the sort of data-driven recommendation there, and I can tell you that there are extensive meetings. Dana mentioned the ACIP group where they really look at all of this. I think probably part of the reason, as Dr. Stevens mentioned, is that 16 and 18, the ones that are most commonly associated with cervical cancer or cancers, have been in previous versions of the HPV vaccine. So as it stands now, if you completed a previous HPV vaccine series in the, importantly, appropriately laid out period of time, because as we talked about, even if it's the 9-valent vaccine, if you get the second dose too quickly, you actually have to restart it. And so I think the takeaway is that no, you don't need to repeat it, probably in part because 16 and 18 are covered, but you will need to repeat it if you got them too quickly together.
So this sounds like it's more of an more of an adult or older issue as opposed to the ones that we're generally trying to get vaccinated right now as youth. But with that, I know I was very surprised when I first heard that that recommendation now is up to 45 you can get that vaccine because I know that I kind of missed that window when I was a kid. So with that, for adults, is this something that you really would recommend happening, at your primary care provider's office? Is this something that you ask your primary care provider, or is this something I saw on your slides you had like CVS as an option? So is this something I can just go in and say to my pharmacist, "Hey, can I get one?" What's the best option here?
I do think that all of the above.
Okay, just get it. Just get the vaccine is basically what I'm okay.
Um,
That sounds
as Dr. Bostic sort of alluded to, though, right? Like the older patients, the up to 45, it is shared decision making. It may not be beneficial. It may have a cost for certain patients. So it is worth a conversation. But certainly there's no need to limit it just to having to seeing your primary care doctor.
okay. Perfect. So this is a great question, and I'm sure that any of you can answer it, especially being at CCHP for many of you. Where can you go to get a pap test if you don't have health insurance or a primary care provider?
So we're lucky, as you mentioned at CCHP, that embedded in the center is the Cancer Services Prevention team. And they their mission is to help uninsured folks identify where to obtain and or sometimes we have like a mobile mammography van for breast cancer. So they have really a ton of resources, as does the center, the Office of Community Engagement through Wilmot, have a ton of information about whether you're uninsured or underinsured, obtain cancer prevention tests, be it, we're talking about cervical cancer prevention, but the Cancer Services Program also addresses colon cancer and breast cancer. So there's a ton of information on their website.
Wonderful.
Primary care is tricky. You can look, if you have insurance, you can look on the back of your card. Otherwise, there are sort of safety net lists of folks who are able to see uninsured patients and, more importantly, help them get insured.
Yes. And I will make sure when I send out the email that I will include information for the Cancer Services Program. And I will make sure that I include it for all of the different regions because I know not everyone here is from Monroe County or the surrounding counties. So to make sure that we can have that available for people to access or share that information. We have a couple more questions, but before we jump to these, Wendy, I wanted to ask you one. So it seems that for the data that you provided about the HPV vaccination numbers, they seem relatively low. I know that they've been low all over, but do you know, having looked, it seems like those are mostly very rural counties. So have you noticed that there's a lower kind of uptick of the HPV vaccination in rural versus in urban? Or is that really just not a major concern?
You're quizzing me on something that I haven't looked into for a while. I believe so, but I haven't looked at the data recently. So to be honest, I'd have to check into that.
Well, and from having your discussions, are there really anything that you can point out as being one of like a main block for rural families from having children be vaccinated, or else even having as an adult vaccinating yourself for HPV? Have you found anything that really seems to be a main concern?
I think, well, what we really were trying to address in our developing these videos was vaccine hesitancy was our starting point. So that's kind of the framing that I'm most familiar with. And talking to parents and others about what would you need to show in the videos to and who is the person who's giving the message in the videos that and what information, including what data, is needed to help somebody make that decision to get vaccinated. One of our videos actually, and it was really nice to see the consistency and with the questions we've received from the audience, one of our videos is actually about how to get the vaccine and includes information about the Vaccines for Children's program and where you can go to get the vaccine if you if you don't have insurance, if you don't have a regular healthcare provider.
That's wonderful. Okay, we are coming up very close to 1 o'clock, so I'm going to make sure that these questions in the box are sent to our panel after this. So I will have the answers sent out in an email probably at the end, towards the end of next week, along with a video recording of this event. So make sure if you have anything in, you can stick it in this last minute, and I'll make sure that it gets out. I would like to point out as well, Jane from Bassett said that they operate 22 school-based health centers, and their HPV vaccination rate is at 61%. So way to go, Jane, and the rest of the school-based health centers. That's very impressive. So first, I'd like to thank all of our presenters for being here today. A special thank you to both Hope and Michelle, our interpreters, for making sure that this is accessible to our deaf community members. Please make sure that you fill out the survey so that we're providing content you're interested in hearing about, and surveys must be completed to receive the continuing education credits. The link is available in your webinar confirmation email that you all have received, and use the link to get in today. It has been recorded. I will send out the link. Thank you again, and make sure you join us for our next community conversation on February 27th, focusing on the impact of using patient-reported outcomes to monitor symptoms and improve health outcomes for patients with cancer. See everyone next time.